Thank you very much. Thank you for the invitation. Good afternoon, everyone. I have no financial disclosures. What we want to do the next 25 minutes or so is discuss patient preparation and the MR protocols for imaging of various uterine conditions. I'm going to go to how do I report a GYN MRI with specific reporting tips and pearls and pitfalls. We're going to review the added value of MRI on treatment selection and planning of patients with both benign and malignant uterine conditions. And as I go through some of the cases, I'm going to highlight a few pearls and pitfalls of MRI imaging. Just starting with the technique, we use both 1.5 Tesla and 3 Tesla scanners, either a pelvic or if you have a cardiac phase coil, that's also excellent. We ask the patient to empty their bladder prior to their examination because what you want is a semi-full bladder by the time you start acquiring the images. We used to ask them to fast for 6 hours, but now we give the antiperistaltic agent. In the US, glucagon. In Europe, you can give both glucagon and Buscopan. We don't use any vaginal gel, and that is, in my opinion, optional. And just to show you two cases here, a case here of a patient which had prior trachelectomy, and I'll talk about that in a minute, which means amputation of the cervix for fertility preservation for a patient with a small cervical cancer. You can see here, before giving antiperistaltic, there's a lot of movement mainly due to the small bowel getting here into the recess. And you can see the same patient, same sitting after the antiperistaltic. You can see how nicely this area of the neo-vagina is seen. And you can confidently say there is no tumor in this case. So what planes do we use? For the uterus, we start with large field of view axial T1 weighted images. We want to look at the para-aortic region, especially for in case of malignancy, as well as in the case of uterine anomalies, you want to make sure that both kidneys are present. Then we do the high-resolution T2 weighted images on the sagittal, axial, and coronal plane, especially for the benign conditions. For uterine anomalies, we use the long axis, so parallel to the plane of the uterine cavity, or a short axis in case of endometrial cancer, which is perpendicular to the plane of the uterine cavity, and I'm going to illustrate those planes to you in a minute. So there we go. There's the sagittal here. If you want to look for uterine cancers to see the depth of invasion, to stage them, then you use an oblique plane, so perpendicular to the endometrial canal. We use diffusion. We have an axial multi-bivalue diffusion, IVIM type, and that's a larger field of view. At the moment, it's used in the research setting. We also do sagittal and axial oblique to match the T2 weighted images with 3 b-values. We do give contrast, and we use multi-phase contrast in both sagittal and oblique axial plane, again matching the T2. In case, let me just emphasize you the plane in case of the uterine anomalies. Just a T2 weighted image here. As you see, it's a retroverted uterus here. This is the standard axial. And you can see here, yes, you probably even can diagnose here septate uterus. However, you need to do a little bit more than that. You need to measure the length of the septum here. And it'll be much more accurate if you really did use a coronal plane here, true coronal to the uterus, so the oblique plane. As you can see in this case here, you can nicely measure the septum and describe the composition of the septum. When it comes to the cervix, again, you need a large field of view axial T1 weighted images to look at the para-aortic region for lymphadenopathy. The high-resolution images, you really don't need the coronal in this case, or at least we don't do the coronal in this case, we do sagittal and axial. In this case, the short axis plane is to the cervix, so perpendicular to the cervix, and here you go, there is a sagittal image here with the tumor into the posterior cervix here. And if you do the oblique plane, so perpendicular to the tumor or to the cervical canal, you have these oblique axial planes, which allow you to actually look at the depth of myometrium invasion, cervical stroma invasion very nicely. We keep the same parameters for all uterine malignancies. So again, diffusion, IVIM on the large field of view, and then sagittal axial oblique on a short field of view with multiple b-values. And then we do give contrast on both sagittal and oblique planes to measure the T2 weighted images. So in a way, you sort of keep some of the sequences the same, but you vary according to the clinical questions to the condition. So you try to sort of personalize a little bit the protocol on the pathology you're looking at. So just to re-emphasize that oblique plane, it has to be true oblique to the tumor, so perpendicular to the tumor. This is a case of a very large tumor, so dumbbell-shaped tumor endocervical. This is the case came from another hospital. You can see the sagittal here. That is the axial to the pelvis rather than to the cervix. I wouldn't fault anybody for calling that a parametrial invasion. You can see the stroma is preserved here. You can see there is no stroma here with tumor, almost with no stroma between the interface between the tumor and the fat. However, the surgeon did say that, well, I think that the tumor is it's free and we don't detect any parametrial invasion. And actually, if you look at the axial oblique case images perpendicular to the tumor, you can see exactly what they mean, and they're absolutely right. You can see that the stroma is absolutely intact, and the tumor is just confined into the cervical canal, although being a large tumor. So how do I report a GYN MRI? First of all, and that's sort of a mental check you do, I'm sure, on everyday basis when you read, you check that all the sequences are available for reporting. Sometimes, you know, the tech might forget to push a sequence through to PACS. I check the quality of the images, and we have a very nice tool now that we give both positive and sort of more critical feedback to the technicians on the quality of the images. Then you need to look at the need for extra sequences or planes, especially if you're supervising your studies. If you work on a small center, then you can supervise the studies. If you're looking for endometriomas or dermoids, or if you saw something high signal intensity on T1 weighted images, then you can ask for the T1 fat set images. And I'm sure you'll hear more in the next talk about this. You make sure the planes are correct. For the GYN malignancies or uterine anomalies, and you also check that the upper abdominal images are there for both the para-aortic region for the lymph nodes and also presence of kidneys. And if you actually supervise your studies, maybe you can get away without giving contrast in certain conditions, and I'm going to reiterate that. But if you actually have a lot of scanners spread out, like we do have along New York and New Jersey, then you probably are better off of actually having a standard protocol which is followed, because you can't really, you know, supervise every single study. But in a small setting, that is actually doable. So before starting to actually dictate your report, you need to know indications for the MRI, and they are obviously automatically populated, but we sort of tailor them accordingly, because there is more information probably on the medical record. What is the intended treatment? Because then you have to mention certain things which pertain to a certain treatment, and we'll go through that in detail. Age of the patient is very important, so is the menopausal status, phase of menstrual cycle, as well as the use of oral contraceptive. And that's really important. Like this case here, you can see that was actually a patient who had an MRI of the spine for back pain, and the person reported it was a neuroradiologist a few years back now, and they thought the uterus was really abnormal. They got worried about the possibility of a sarcoma. But actually, this is a classic appearance of somebody with a long-term oral contraceptive when you actually have a lot of endometrial and inner myometrium junction zone atrophy and the globular myometrium. So, you know, once you know the pitfall, then you can easily sort it out. And that was actually the case when the patient was asked. You have to ask for use of hormone replacement therapy, because you have different thresholds for endometrial thickness, and then, of course, the risk of polyps and endometrial cancer. And, of course, any pertinent OB/GYN history. State the indication for the exam, describe the sequences used, and this pretty much in our hospital actually comes automatically, so we don't actually need to do that. You have to adapt it if you gave antiperistaltis or not, just to make sure you're accurate. In the uterus, presence, positional orientation, you have to really state that. Size in 3 dimension. It's very important because sometimes they decide on the approach. Endometrial thickness, obviously, comment on the junction zone if it's thickened or not, presence of adenomyosis, and comment on the cervix. Ovaries, obviously, presence, size. We don't usually measure ovaries unless they're abnormal, and then you have to give measurements. But otherwise, you know, the ovaries appear normal, no adnexal masses will actually suffice. And just a word on free fluid, because we overuse the word ascites all the time. If there is a small amount of fluid in the pelvis, especially in the patient's premenopausal, you don't have to say there is ascites present. Ascites has got a pathological connotation, means that it's actually malignant cells, so, or due to, I'm non-malignant, but due to a pathology. So I use free fluid in my report. Uterine anomalies, again, presence, position, orientation, configuration, size of the uterus. If septated, you must state if it's complete or partial, muscular or fibrous or both, and the length of the fibrous part, and we saw that case already. If unicornate, you have to state if there is a rudimentary horn, if it's communicating or not, and if there is active endometrium within a horn, and that's important. And again, I'll show you a case because it really is crucial when you plan the treatment. And for the ovaries, we just went through that. But in the case of uterine anomalies, there is a strong association with polycystic ovaries, so you have to mention them when you think they have a polycystic configuration. And of course, unicornate uterus has a high association with endometriosis and hematosalpinx, so again, you have to mention that on your report. And again, if the kidneys are present, absence, or the duplex system. Just to show an example of uterine anomalies, that's actually a 15-year-old who came to the hospital with a raised CA125, around 400-500, and with abdominal pain. The ultrasound described a normal uterus and a left adnexal mass suspicious for ovarian cancer, which statistically probably was unlikely at the age of 15, but in the raised CA125. So we did an MRI. As you can see, this is a classic appearance of a unicornal uterus with a banana shape. Cavity, and then you can see the other cavity, which is a non-communicating, and there is blood products. You can see on T1 fat cell image, you can see these hematosalpinx here. So that's what we said, and what they do, they go in and actually they resect this horn, and of course there was no evidence of malignancy. Just put everything into the context: the age, the symptoms, and as well as the imaging appearances. Leiomyomas and adenomyosis, I've grouped them together in the interest of time. Again, you mentioned the size of the uterus, the junctions on thickness, obviously for adenomyosis, presence, size, and position of leiomyomas. This is important for treatment planning. Is there a compression of adjacent structures, type of degeneration, as well as any suspicious features? And I'm going to give you an example of that. And obviously, you got to comment about the ovaries. If a case is planned for uterine artery embolization, you have to comment on the vasculature. Is there an ovarian uterine artery anastomosis or not? That is really important for treatment planning. And of course, presence of hydronephrosis, which doesn't mean that that's a sign of leiomyosarcoma, because large leiomyomas can cause hydronephrosis. Now, moving to the uterine malignancies, it's been a really long way, especially in the US, to actually try to and accept MRI as one of the ways to evaluate extent of tumor in an endometrial cancer. I'm not using the word staging because it gets some of the clinicians a little bit too anxious if we say we can stage it with MRI, but actually we can. So, and finally, NCCN, this is the 2017, just out of the press, it does recognize the role of MRI in several sort of indications, and that's quite a lot of achievement from the imaging community to establish the origin of the tumor, endometrial versus endocervical, when you have an endometrioid cancer pathology. Definitely for fertility sparing, and I'm going to show you an example of that. For suspected cervical involvement, as well as for type 2 histology, so serous papillary and clear cell carcinomas, you can use it for staging, and of course for recurrence. So we do actually have got a long way in the US. France was always very pro-MRI, and they have it as part of their staging, and of course the imaging societies have MRI as their modality of choice. But what we need to do is actually get the imaging into the clinical guidelines, not just into our imaging societies. So how do I report an MRI for the endometrial cancer? State the tumor grade, the cell type. Is it a adenocarcinoma, or is it a serous papillary type, or is it a clear cell type? And the CA125 level, if that was done. Because if you actually notice on the labs that the patient has a raised CA125 level, then you worry already about the peritoneal spread. And it makes you look extra carefully to the omentum and the paracolligators and the ovaries, because then the type of surgery would be the one that you do for ovarian cancer rather than the one for the endometrial cancer. The tumor appearance, the size, the morphology, if it's heterogeneously enhancing or not. And sometimes I put some sort of notice on how it looks on the ADC map, and I'll give an example later on. And of course, tumor extent, depth of myometrial invasion, is it superficial, is it deep, involves the serosa or not, is there any cervical stroma invasion? Just don't forget the endocervical extension doesn't change the staging anymore, but cervical stroma invasion makes it a stage 2. And of course, is there any extrauterine extension into peritoneal disease or lymph nodes? And so you can see in this case here, it's a deep invasion of this endometrial cancer, and there is bilateral ovarian metastasis already. That's a case of a serous papillary tumor. Again, your report will stratify the patient because none of that is actually available. Well, perhaps the cell type, and I'll discuss that later prior to surgery. All these then will become available after the surgery, and you really want it before the surgery. So it's a lot of, it's one of the really good papers in this field. It's written by one of my colleagues, Alberto Vargas, looking at tumor location, endometrial versus endocervical. And it's actually pretty simple when you think about it. You have to identify the internal cervical os. And if the majority of the tumor is actually cranial to the endocervical os, that's going to be an endometrial cancer. And you can see here after contrast, just another image. And if the majority of the tumor is caudal to the internal cervical os, then this is going to be a cervical cancer. Why is it important? Well, it is very important because they cannot sort out it in pathology, but the treatment might be, it will be different because the type of the extent of the parametrial excision you do is different for endometrial cancer compared to cervical cancer when you actually do a very time procedure and you do a very wide parametrial excision. So just a word on fertility preservation and endometrial cancer. This is actually very important since we're seeing some more and more young patients who require fertility preservation, or rather require or actually want fertility preservation. Because of the widespread obesity, we're seeing endometrial cancer in young patients now. So it's not the standard of care, but many institutions like ours do offer it, at least give it a trial. There are certain criteria, FIGO grade 1 endometrial cancer, absolutely no myometrial invasion, that's where the MRI actually enters the equation, no synchronous ovarian tumor, no ovarian metastases, no nodal metastases, obviously no Lynch syndrome, and no contraindication to progestin, which is the treatment they do. So in our institution, those patients have an MRI to actually exclude presence of any myometrial invasion, so this is really important. Otherwise, they'll be ineligible. And just to show you a case here, you can see on T2, it actually does look smooth, but it's very important to see this very smooth subendometrial enhancement line, which is completely intact here. You can't hardly see the tumor. You actually cannot see the tumor on this T2, but the junctional zone is completely intact. So this was confined to the endometrium, and the patient successfully received treatment with progestin. Compared to this other one, when the tumor is larger, it expands the endometrial cavity, a little tougher on those T2-weighted images actually to see the invasion. But very nice here after contrast, you can see this subendometrial enhancement line is actually interrupted. And you can see this sort of frontal leg of the tumor invading into the inner myometrium. So very important to keep in mind. And they do follow this patient with the MRI and biopsy to make sure there is no progression and there is complete response after treatment. There are several staging considerations one has to take into account in endometrial cancer. The majority of patients are actually stage 1 diagnosis. It's very important the depth of myometrial invasion because if you actually have a deep myometrial invasion case with a grade 3 or a type 2 cancer, serous papillary or clear cell, your chance of para-aortic lymph node metastasis goes from 4% up to 6% to actually 40%. So this is how important the myometrial invasion is. So is it easy? Well, nothing is easy, but now we have a lot of tools, so you can use both, all three, T2, diffusion, and dynamic multiphase contrast enhancement, and there is a lot of literature on that. And if you look at various studies, they propose the combination of one or the other, but basically both diffusion and DCE probably perform equally with a little bit better diffusion in this meta-analysis. And actually, I am a strong believer that if you did supervise your endometrial cancer staging on your MR scanners and you got nice diffusion-weighted images, you really don't need to give contrast. But if you don't supervise them, then it's better off to actually give contrast because you don't know if the diffusion images are actually good enough. There's been some very elegant work done by one of my colleagues, Stephanie Nougare from Montpellier, looking actually at tumor volumetry and also the volumetry of the ADC as well. She showed that if the ratio between the tumor and the uterus volume was less than 25%, then there is no myometrial invasion. But if it was more than 50%, all cases had deep myometrial invasion. So that can be potentially actually applied, and you can do it in your scanners, and it does give quite a lot of information to the clinicians. Just a couple of stages for the as examples. This is a case of endometrial cancer, again on T2. It's a little tough. Maybe you can say, well, it's definitely not outer myometrium, and maybe it's really irregular. Maybe you've lost a little bit of junctional zone here posteriorly. After the contrast, just remember the tumor is of low signal intensity, no enhancement. It enhances less than the adjacent myometrium. And you can see on the ADC map here, on the diffusion weighted here, it's bright and will be dark on the ADC. I'll show an example in a minute. What I want to point out here is this bright area, which I've seen it called before a myometrial invasion. This is just peritumoral inflammation. It's a very, very nice paper from our Japanese colleagues here, and I encourage you to read because it is a pitfall that you'll encounter very frequently. So again, peritumoral enhancement is an inflammation. It's actually not deep myometrial invasion. Just to show you the type of images you can actually get, this is a 1.5 Tesla, just really standard. And you can see a large endometrial tumor here invades a little bit more than 50%, probably on the sagittal. Nice to have those really perfect obliques because you can see here in both T2, contrast, diffusion, and ADC maps that the tumor does invade into the outer myometrium. Again, if you get this quality of diffusion, you can actually cross the contrast and save some time and money in the scanner. Cervical stroma invasion, I think contrast does have some value when it comes to cervical stroma invasion, and so the diffusion actually can do the same. You can see this is a tumor here which extends into endocervical canal. On T2 it's a little tough. Is it actually invading or is it just pushing the cervical stroma to the back? Much easier here on these post-contrast images. You can see tumor is infiltrating, kind of eating out into the cervical stroma posteriorly, and that was indeed cervical stroma invasion. Very, very important because those patients have vaginal brachytherapy after their surgery. So you can counsel a patient before actually they start their treatment. Just to give you many phases of sort of stage 3A, at this point, you probably don't need anything beyond the T2 anatomical images. This large tumor, obviously, the serosa is gone here. You can see the tumor is outside the uterine contour. This is a case of a septate uterus with a small adenomyoma in the septum, just to spice the case up. But that's an endometrial tumor here with the tumor growing into both fallopian tube and the ovary. So definitely, that's easy on the T2. That's another case here with tumor with a match in the ovary. That's the primary endometrial cancer here. And then it's tumor walking into this fallopian tube, which is distended with tumor. It can be subtle. So I think diffusion does have a role here. And this is a case of serous papillary adenocarcinoma. So you can see there is deep myometrial invasion. It's actually less than what one thinks on T2, but still was deep at pathology. If you look at the T2s, you really wouldn't think anything on the anexa here on the left, but on diffusion-weighted images, it's hard to ignore this bright spot here, and you can fuse the images. That usually does help to actually promote the modality, especially with the surgeons and the oncologists, because it's like nice colored pictures, and that's what we're supposed to do as radiologists. And you can go back, I can see the anexa here. You can see there is a really indistinct area. We called it because the serous papillary was very strict to diffusion, and the CA125 was high, and indeed it was an 8 millimeter deposit in the surface of the left ovary anexa. So that's a very nice case given to me by my colleague and friend, Professor Togashi from Kyoto. A large endometrial cancer, obviously invading the cervical stroma here. There is a little tumor sort of nodule in the serosa there, so definitely a 3A. any vagina involvement, really hard to say on those T2-weighted images, but then you fuse them with diffusion-weighted images, and it's just, even retrospectively, I don't think, maybe with the eye of faith you can see that part here, but you know, this lower vagina here, I wouldn't have picked it up on a T2-weighted. So I think diffusion is excellent when it comes to really small lesions, and like drop lesions in the adnexa, in the cervix. So I suggest using that because it's quick as well. So endometrial cancer aggressiveness, there's been a lot of literature on that, on diffusion-weighted images. There is some contradictory sort of evidence, but by and large, I think there is now sort of some consensus that there's a difference between grade 1 and grade 3, but there's no difference in grade 2 and grade 3 endometrial cancer. And actually, there is a nice talk in tomorrow morning session at 8 o'clock on looking at different ways of looking at tumor aggressivity on endometrial cancer. There's also a relatively recent paper here, which is actually quite nice, again from Japan group, looking at DCE, and again there is indication here that you can actually predict the type of endometrial cancer, type 1 versus type 2, grade 3 serous papillary and clear cell, using the dynamic contrast analysis as well. And just to point out this very nice case given to me by my colleague, Professor Anwar Padani from Mount Vernon in London. And we actually see that not very infrequent now. This is, as you can see there, this is the diffusion B0, B500 and ADC and the fused images. I just want you to appreciate that there is different shades of gray in this ADC. And although this patient had a grade 1 endometrial cancer at a biopsy prior to surgery, what the biopsy missed is the serous papillary cancer at the back here, which is actually the worst prognosis part of this tumor. So we do actually use this. We eyeball it, but you can also measure it. We actually use this in the report. And sometimes I do say on the report, like I do for prostate as well, the degree of restricted diffusion suggests presence of a type 2 or presence of a higher grade tumor. So they actually are extra careful for that when they treat the patient. Very quick on leiomyomasarcomas. That's a whole holy grail. What do? You can distinguish very easily the garden variety leiomyomas from leiomyosarcomas. The problematic is the atypical leiomyomas or cellular leiomyomas from leiomyosarcomas. And there is some elegant work done by my colleague here, Dr. Lackman, in combining certain features as described here, the nodular tumor borders, T2 dark areas, hemorrhage on T1, as well as central necrosis. And if you combine, if you have 3 or more features present, that actually you have a very high sensitivity and specificity to actually diagnose it. So you really have to get all the information together in order to achieve that. Diffusion, there has been some recent work there. The problem is there is always overlap in the ADC values. So I think we need to do a little bit more work on diffusion in order to actually use it effectively for this purpose. Just moving to the last part on cervical cancer, what are the MRI indications? Well, origin of the tumor, we already covered that. Selection of fertility sparing, and I'm going to spend a minute on this. Evaluation of parametrial invasion, that's the key question. Oh, I'm sorry. Radiotherapy planning and follow-up, and of course, evaluation of tumor recurrence. And finally, the suitability for pelvic exenteration, or like we call it now, pelvic reconstruction. So what does the MRI report say? Again, tumor grade, cell type, FIGO stage, you got to state it, if it's available, tumor appearance, and tumor extent, parametrial invasion, hydronephrosis, vaginal, bladder, rectal invasion, of course, metastases and lymph nodes. So these are the criteria for trachelectomy, which means amputation of the cervix, a little bit of upper vagina, and the lower cervix and the lower uterine segment. And you have to accurately measure the distance. So, and again, this is some nice work done by Dr. Lackman here. If there is, you have to measure distance between the tumor and the internal cervical os. You can see here is very close to, definitely less than a centimeter. On the other case here is more than a centimeter. This case did not have trachelectomy, unsuitable. This case is suitable because the tumor is more than a centimeter from the os. Parametrial invasion, when it's subtle, it's more difficult. Obviously, when it's a big tumor, it's more difficult because it's adjacent stromal edema. And an intact low-intensity stromal ring will gives you a high negative predictive value for excluding parametrial invasion. This is a small tumor. You can see this little lip of tumor here outside. Does the diffusion help? It does increase your confidence. You can see this sort of little bit of tumor going out into the parametria, and you can see there on the fused images, this patient had surgery because she had ulcerative colitis, so she couldn't have radiotherapy, and indeed she had parametrial invasion on the right. This is gross parametrial invasion. You can see there is spiculated tumor to parametrial interface. Here there is tumor, frank tumor, or soft tissue extension into the parametria, and then encasement of the periuterine vessels. Then we got into the advanced disease, and with this case, I'm going to illustrate all stages of the disease. And again, when it comes to this stage, you really don't need probably diffusion or contrast. It's just so advanced, and luckily we don't see them that often. But you can see here 3A, stage 3A vagina, lower vagina. Hydronephrosis is stage 3B, and you can see there bladder invasion is a stage 4A. And you can combine, of course, diffusion and fuse your images. And there's a small note here, which you can't say much on the ADC alone or the fused images, but you go back to the T2 and you can see this node is round, and it's on the side of the parametrial invasion, which makes it highly suspicious for metastasis, and indeed it was. So with 1 second left, this is my last slide. So take-home points. It's imperative to optimize the MR technique and beware of person pitfalls. The use of pathology-specific report is crucial, and it's crucial you talk the same language with your clinicians. And MRI does play an important role and added value in all those indications that I discussed with you. And again, it's working with the clinicians is how we promote our modality and the value and the added value of modality. I just want to thank my super team here, Dr. Vargas, Nugara, and Dr. Lackman for just making my work fun. Thank you very much.